Good evening. My name is Rich Fazzillo, and I'm the Executive Director of the New England Hemophilia Association. I would like to welcome you to tonight's webinar hosted by the Boston Hemophilia Center and the New England Hemophilia Association. The title of tonight's presentation is called The Pros and Cons of Hemlibra Therapy for Hemophilia A. Before we get started, I'd like to go over a few webinar points and helpful hints. Tonight's webinar will last approximately 1 hour until 7 p.m. Eastern Time. We welcome your participation and questions. Your audio will be muted by the system for the duration of the webinar, as this helps eliminate background noise that may disrupt the presentation. If you have a question, we encourage you to use the question box on the bottom right of your control panel. I will pass these questions along to our speaker at the end of the presentation. Again, in the control panel, there is a question box. Simply click that and type your question in there. The views expressed in the presentations tonight made this evening are those of the speakers and not of NEHA. Our speakers tonight are Dr. Aric Parnes and Dr. Stacy Croteau from the Boston Hemophilia Center. I'm going to give their bios and then I'm going to turn it over so we can start the presentation. Aric Parnes is a benign hematologist in the Division of Hematology at Brigham and Women's Hospital and an instructor in medicine at Harvard Medical School. He serves as the Associate Director of the Boston Hemophilia Center and Assistant Program Director for the Hematology Fellowship Training Program at Dana-Farber Cancer Institute. His time is divided by clinical practice, clinical research, and teaching. His research encompasses bleeding disorders and hemostasis and thrombosis. Outside of work, you can find him cheering on his 2 children playing soccer. Stacy Croteau is a pediatric hematologist and clinical researcher at Boston Children's Hospital, where she specializes in bleeding and clotting disorders. She completed her undergraduate and medical education at Brown University and then pursued training in pediatrics and pediatric hematology oncology at Boston Children's Hospital and the Dana-Farber Cancer Institute. Dr. Croteau is the director of the Boston Children's Hospital Hemophilia and von Willebrand's program. Her primary area of academic interest are early drug development, advancing an approach for rationale designed personalized prophylaxis regimens in hemophilia, and quality improvement efforts for targeting patients' transitions from pediatric to adult care. So without further ado, I'm going to turn it over to Dr. Aric Parnes to start the presentation.
Thank you, Rich. So today, Dr. Croteau and I will be talking about Emicizumab and its pros and cons. Here are my disclosures. Importantly, we have received research funding from Genentech Hoffman LaRoche as we participated in the clinical trials for Emicizumab, but they are not part of this webinar. So here is the clotting cascade, and I wanted to show you this because it is so complicated, and there's so many moving pieces to it. And any of these clotting factors can be missing, causing a bleeding problem. The 2 main ones, however, are factor 8, which is missing in hemophilia A, and factor 9, which is missing in hemophilia B. I've simplified this cascade into its 2 main pathways, the intrinsic pathway and the extrinsic pathway, and I've left out 8 so you can see where the disconnect happens for hemophilia A. And
Dr. Parnes, I don't mean to interrupt. I don't think we're seeing your screen.
Oh, what are you seeing?
Just the landing page. I think there's a button just to hit to show your screen.
Where do I find that button?
Let me try to give it to you. Drive technology. Let's try this. Let's see. All right, it should come to you right now.
Ah, sorry.
There we go.
I see.
No, perfect.
Okay, I'm backing up. Here are my disclosures. I'll race through this. And here's the complex clotting cascade. where we are missing factor VIII in hemophilia A and factor IX in hemophilia B. And this is the simplification of that cascade into its two main pathways, the intrinsic pathway and the extrinsic pathway. And I've purposely left out VIII to show you the disconnect between in hemophilia A, where the intrinsic pathway is not able to complete the cascade to the common pathway. And we have dealt with this for treatment by simply replacing the missing factor. So we're able to infuse factor VIII to complete this clotting system. And by infusing factor, we're able to treat acute bleeds, and we are able to prevent bleeds, and we're able to prevent the complications of bleeds, such as hemophilic arthropathy, the joint damage that occurs with each joint bleed. And we see that there is a wide range of manifestations in terms of severity, but we categorize patients as mild, moderate, and severe based on their factor level. So severe patients have undetectable factor, and mild patients, the factor levels are over 5%, moderate somewhere in between 1 to 5%. And this has, even though these are small numbers, the outcome is quite dramatic, where severe patients can bleed spontaneously, and mild patients typically do not bleed spontaneously. They will bleed when they have trauma or surgery. So severe patients, because they are bleeding spontaneously, require factor replacement on an ongoing basis in order to prevent that from happening. And it was through many studies over time that have shown us that prophylaxis does prevent bleeding and long-term joint damage. This is one of the major studies showing that, the joint outcome study published in New England Journal over a decade ago. And the patients who were treating on demand had a lot of bleeds, whether they were joint bleeds or other bleeds, compared to the group doing prophylaxis, where their bleeding rates were significantly diminished. And so over time, as these studies were published, and many studies really supporting this, we have shifted our practices to really promoting prophylaxis in order to prevent bleeding. But prophylaxis comes with a cost, and it's a significant cost in terms of dollars, but also in terms of effort, because factor VIII only has a half-life of 12 hours. That means in order to have a successful prophylaxis strategy, you end up needing to infuse factor every 2 or 3 days. This is a huge treatment burden for patients, an inconvenience, and it can damage patients' veins and make it more difficult over time to achieve venous access. Some patients require ports, and ports can become infected. So the demand, this practice of doing prophylaxis has a significant burden that we as providers can appreciate. And so great effort has been made over the years to improve factor so that this burden is made easier. And just a few years ago, long-acting factors came out. And this was made possible by adding molecular structures to the factor protein so that it wasn't metabolized as quickly. Structures such as FC receptors, this is part of an antibody, pegylation, and binding other proteins like albumin. And it worked pretty well for factor 9 in hemophilia B. The half-life curve was extended enough that patients often can get by with doing prophylaxis maybe once a week, sometimes even longer. But it didn't work that well for patients with factor 8 deficiency, the half-life being extended from roughly 12 hours to maybe 20, 24 hours. Then somebody came up with the idea of making an antibody that could mimic the function of factor 8. So factor 8, if you remember from that crazy clotting cascade I showed you, binds to factors 9 and 10, brings them close together, and then the clotting cascade can continue. So this group in Japan made an antibody that will do just that. It will grab factor 9 and factor 10, bring them close together, and then the clotting system can continue. And so this strategy has several benefits. The first one is that because it is not a clotting factor, it has the potential to work for patients with inhibitors or without inhibitors, so that an inhibitor is an antibody that blocks factor, but Emicizumab is not a factor, so it doesn't get blocked. Because it's an antibody, it can be administered subcutaneously, and we don't have to search for a vein. And then its half-life. Previously, factor 8 had a half-life of about 12 hours. Emicizumab's half-life is 30 days. So these pros, Emicizumab pros, have potentially a large impact for our patients. Later on, we will talk about the cons, the downside to Emicizumab. So this initial work was first supported in the laboratory by taking blood from patients and adding Emicizumab and finding that their clotting times became normal. And then these experiments were also done in animals before giving Emicizumab to healthy volunteers who did not have hemophilia, and those healthy volunteers had no side effects, no complications. So the first 18 patients were then given Emicizumab. These were all severe hemophilia A patients. 11 of them had inhibitors and 7 did not. When they did well, the trials were scaled up in the Haven series, Haven 1 through 4. Haven 1 gave Emicizumab to 109 patients with inhibitors. Haven 2 looked at 60 patients in the pediatric setting, all with inhibitors. Haven 3 looked at 150 patients who did not have inhibitors. And then Haven 4 tried to extend the duration to once a month dosing compared to the other studies that used once a week or every other week dosing. The initial 18 patients were reported in the New England Journal of Medicine in 2016. And it was a very short study. It only lasted 12 weeks. And again, 11 of the patients had inhibitors, 8 did not. They had minimal side effects, but they did have a dramatic reduction in their bleeding rates. So before they were doing Emicizumab, they were having on average 15 bleeds a year, and this went down to 0. And so the studies were then scaled up. I'm going to skip to the Haven 3 study, and Dr. Croteau, when I'm done, will come back to the others. So the Haven 3 study is the study that looked at patients without inhibitors. And the main focus was on patients who were not doing prophylaxis beforehand. So these were patients who were bleeding more frequently. They were treating on demand as needed. And those patients were randomized to 3 arms. Arm A, where they received Emicizumab weekly. Arm B, where they received Emicizumab every other week. And Arm C, where they were left not receiving Emicizumab, but only treating on demand with factor VIII infusions for 24 weeks as a lead-in before they were put on Emicizumab every other week. And this allowed a comparison group to see how patients did concurrently. Arm D was for patients who were already doing prophylaxis with factor VIII infusions. They were all switched right over to Emicizumab weekly. And this is how they did. The patients who received Emicizumab weekly had a dramatic reduction in their bleeding rates with 1.5 bleeds per year, very similar in the every other week group at 1.3 bleeds per year. And this is compared to 38 bleeds per year for the group that didn't switch over for those 24 weeks, the on-demand group. The group that had been on factor VIII prophylaxis beforehand had 4.8 bleeds per year, and this was significantly improved with Emicizumab down to the 1.5 bleeds per year. That's a 70% decline from factor VIII prophylaxis to Emicizumab prophylaxis. It's also striking to see how many patients didn't require any additional factor infusions. It's important to note here that Emicizumab is only for prophylaxis prevention. It is not to treat acute bleeds. So when a patient has an acute bleed on Emicizumab, factor infusions or bypass agent infusions, if an inhibitor is present, are still required to treat that acute bleed. But what was fascinating was that in the weekly Emicizumab group, 56% of the patients reported requiring no additional factor infusions, and almost the same 60% in the every other week group did not require any additional factor infusions. The on-demand group, who was not on Emicizumab, but only treating on demand, every single patient needed to infuse factor for bleeds. That's not unexpected. But how about the factor VIII group, the group that was doing factor VIII prophylaxis before changing over to Emicizumab? 40% of those patients required no additional factor infusions besides their prophylaxis. And this is noticeably different than the Emicizumab group. So there are some downsides, and Dr. Croteau is going to go into this in more detail than I will. But I just wanted to point out a couple things. So as I mentioned, Emicizumab is not to treat acute bleeds, and factor infusions are still required if bleeding occurs. Injection site reactions were the most common side effect noted. So pain, swelling, some kind of irritation where the injection was in 22%. And then this is new data just coming out that there were some anti-drug antibodies that were seen. In all of the Haven studies, there were 14 patients who developed an anti-drug antibody. But most of those were either transient or they had no effect on the actual treatment. there were 3 patients, 3 out of those 14, where the anti-drug antibody made the emicizumab work less well. And those patients were switched back to their previous treatment without any problems. There were no other complications. There were also not in the Haven 3 study, but elsewhere. Dr. Croteau will talk about the blood clot and thrombotic microangiopathy issue. I wanted to also show you that the patients were surveyed about their quality of life in the Haven 3 and Haven 4 studies, and 94% in the Haven 3 study preferred emicizumab over their previous treatment, 100% in the Haven 4 study. Only 2 patients out of 95 preferred their previous treatment. The reason that they had listed saying that that they preferred emicizumab over their previous infusions was because it was more convenient in terms of the longer half-life and the subcutaneous administration, better quality of life, but overall they were just less worried about bleeding. It was interesting that even though 2 people preferred their old treatment, everybody stayed on the emicizumab. And with all of this data, just a few weeks ago, the FDA granted an expanded indication for emicizumab to include not just patients with inhibitors, but also patients without inhibitors and of all ages. So with that, I will turn it over to Dr. Croteau.
Excellent. Thank you, Aric. Excellent. So hopefully folks can see my screen. Good evening. Now that we have this excellent foundation that Dr. Parnes provided, let's jump into thinking a little bit more about this concept of emicizumab as a new approach for prophylaxis in hemophilia A. So as Dr. Parnes reviewed with us, we've talked a little bit about what emicizumab is and how it works. But now we're going to do a bit of a deeper dive into how emicizumab has been studied in people. And as you heard, this is what has been called the Haven program, the later stage clinical trials investigating emicizumab therapy. We'll talk a little bit about what has gone well for patients receiving emicizumab. And then we'll talk in a little bit more depth about what issues have arisen for people receiving emicizumab. And then in the end, we'll begin to broach some of the things that we know we need to learn more about in opportunities for more clinical research investigating emicizumab in both inhibitor and in non-inhibitor individuals. So how many people have been exposed to emicizumab? La Roche-Genentech updates this number from time to time. It was most recently updated as of August of 2018. And at that point, more than 1,100 patients with hemophilia A, both with and without factor VIII inhibitors, had received emicizumab globally. And this number includes both adult and pediatric patients that participated in the clinical trials and in other programs that they had to provide access, including expanded access, compassionate use, and in the post-marketing setting. As you can imagine, once a drug becomes licensed, especially licensed in many countries across the globe, it actually becomes more difficult to know exactly how many patients have ever been exposed, but certainly starting with a good foundation of patients so far. When we dive into the Haven program, and those are the clinical trials that Dr. Parnes discussed a bit briefly earlier on, Haven 1 was the first pivotal, or that first clinical trial with an intention of submitting information to the FDA to get an indication, to get a license and approval. And as you heard, this was conducted in both adolescents and young adults, or AYA, as well as adult patients with hemophilia A with inhibitors. So young men from anywhere from 12 to 75 years of age, they were looked at with weekly prophylaxis. So within this study, there was 109 patients total, and about a little under a third, 32 patients, were in that age range of 12 to 18. The Haven 2 study looked a much more focused investigation in pediatric patients, again, hemophilia A with inhibitors. And so this really targeted male hemophilia A patients with severe factor VIII deficiency less than 12. There was a little opening for some slightly older patients, those adolescents, young adults who were smaller and didn't weigh quite enough to meet criteria to participate in the Haven 1 study. In the pediatric study, they also were looking at emicizumab prophylaxis, and this study had a total of 60 patients. And you can see the breakdown by various pediatric age groups that follow. So the bulk of the patients, about 38 of patients, were age 6 to less than 12 years of age. The next group, about 17 patients, were 2 to 6 years of age. And then 5 patients were less than 2 years, and the range there was 1 month to just under 2. So as you can see, much of the data, as is always true early in clinical trials, focused first on the adults and even the older teens and adolescents. And we do have some nice pediatric data, but the numbers get smaller, particularly the younger we go in the pediatric age group. You've heard in more detail about Haven 3 already. So this was the first big study looking at hemophilia A without inhibitors, a total of 152 patients. And there was a small group here of males 12 to 18 years of age, just 8 patients. And then in the last study that we'll mention, Haven 4, again, a smaller study looking at our ability to dose emicizumab for prophylaxis less frequently, now just dosing it at 1 month. It included 41 patients, and just 3 were under 18, but again, in that 12 to 18. So for our very youngest patients, really the data that we're working on comes primarily from Haven 2, and from the adolescent young adults, we have achieved some data from each of these Haven studies. So emicizumab administration, as you heard Dr. Parnes say, this is exciting in a way because it is subcutaneously administered as opposed to an intravenous injection. So to be administered subcutaneous, that's like insulin, or for some who might remember interferon alpha, basically you give a pinch of the skin and then you inject just under the skin. Emicizumab comes as a ready-to-inject, colorless, slightly yellow solution and is single use. So unlike current factor products where there's a mixing step involved in various ways, this medication you just draw up. And similar to what some people will be accustomed to with factor, ideally emicizumab is stored in the refrigerator in its original carton to help protect it from light. You're not supposed to freeze it. You're not supposed to overshake it. Unopened vials can actually be brought out of the refrigerator and then returned to refrigeration. But the goal is to keep the temperature and the total combined time out of the refrigerator not above 86 degrees Fahrenheit and not more than 7 days total. So this is a little different than what you hear us advise for factor concentrate once it comes out. It remains at room temperature and also gives you a bit more flexibility potentially when you're traveling with some in and out of the refrigerator time. But still important to remember, like factor, you can't freeze it and you can't get it too hot either. And there's a number of places on the body that work particularly well for subcutaneous injection. So our little man here to the bottom right gives us a sense that the upper part of the arms, the abdomen, the outer part of the thighs, it depends a little bit on the individual, but it's still important to rotate where you're doing your injections, just like it's important to rotate your veins, but there's lots of opportunity on the body to do your injections. Dosing of emicizumab is the same regardless of whether you have an inhibitor, had an inhibitor, or have never had an inhibitor. So everyone begins with a loading dose of 3 milligrams per kilogram per week for the first 4 weeks. And then many of the studies were conducted, as you heard, with weekly dosing. So the weekly dose is 1.5 milligrams per kilogram weekly. And then to get to every other week dosing or monthly dosing, they basically just summed the dose together. So 3 milligrams per kilogram every other week, or 6 milligrams per kilogram per dose monthly. Emicizumab comes in various vial sizes, and so this is analogous to factor as well. As you can see, you have 4 available vial sizes there. So just like factor, in some cases, if your dose doesn't land close to a predetermined vial size, For example, if you needed a dose of 120 milligrams, it's very possible that you would end up receiving two 60 milligram vials that you would need to draw into the same syringe, as opposed to receiving one 150 milligram vial and then wasting 30 milligrams. And so the nice thing is that the volume of many of these is such that you hopefully will still only need to do one injection, but you may have to use multiple vials. And it is worth noting that as you go from weekly to every other week or monthly with those dose increases, certainly you'll need a larger dose. And in some cases, depending on your body size, you may actually have to administer those with two separate injections, because generally we like to not give subcutaneous injections that are more than 1 ml. So if your 6 milligram per kilogram dose, for example, ends up being more than 150 milligrams, it's possible it would be two subcutaneous injections to achieve less frequent dosing. So what's gone well for patients who've received emicizumab? So in the very first study, the HAVEN study, we were able to demonstrate that emicizumab prophylaxis for inhibitor patients is much better than on-demand treatment. So what you can see in the big blue bar to the left of the screen is that for people who were not on prophylaxis, and they're inhibitor patients, so this would have been prophylaxis with bypassing agents, such as recombinant 7A or an APCC, those patients had a number of bleeds per year. So about in the 50th percentile was around 23 bleeds per year. Like everything, there's always a range. So we often present the middle numbers, but it's important to remember that some patients actually suffered with a lot more bleeds, so upwards of 44 bleeds per year. Others had less, around 12 bleeds per year. But essentially everyone not on prophylaxis was having bleeds, and there was about 18 patients in that group initially. When you compare that to the once-a-week emicizumab prophylaxis, and this group had 35 patients in it, you can see the dramatic, almost 90% reduction in bleeds. So these individuals, the 50th percentile was right around 3 bleeds per year. There was still a range, so some had less than 2, some had 5, and everything in between. But you can see the important marked reduction, and this was really the first time that we've had good prophylaxis for a lot of inhibitor patients, as many of you may be familiar. Also, if you look at inhibitor patients, emicizumab prophylaxis seemed to be better than bypassing agent prophylaxis as well. So they took a group of patients, and you can see that there's a dark gray bar at the very top, who were on prophylactic treatment with bypassing agents, meaning they were taking it on a standing schedule, whether or not they were bleeding. And then after monitoring them on their bypassing agent prophylaxis and looking at their bleed rates, those patients then started on emicizumab prophylaxis, and they looked at their bleed rates. And this is what they saw, and this is an example of 24 patients. So each of the numbers on this slide represents a different patient. And again, for each of these patients, you can see the dark gray bar represents the number of bleeds that they were having averaged over a year on bypassing agent prophylaxis. You can see most everyone has some larger bars, and then the light gray bar looks at their bleeding rate on emicizumab prophylaxis. So there's a few things to key in on here. So on the right-hand side of the screen, for a number of patients, they were having many bleeds. So as few as 4.5 and as many as 44, even though they were taking bypassing agents regularly. And switching to emicizumab prophylaxis, that bleed rate went down to 0. There were some patients who were actually doing quite well on bypassing agent prophylaxis and didn't happen to have any bleeds while on bypassing agent prophylaxis. And after they switched to emicizumab, they continued to do well and continued to not have any bleeds. And then there was another group that had a number of bleeds on bypassing agent prophylaxis, but still continued to report bleeding episodes despite emicizumab prophylaxis. And this is a group that requires a bit more investigation. As many will appreciate, sometimes it can be difficult to sort out whether there's a bleed happening or a flare of arthritis or injury that people worry could turn into a bleed and some preemptive treatment. So whether some patients didn't respond quite as well or were truly having hemarthroses and significant bleeds despite emicizumab prophylaxis and perhaps needed a different dose or additional considerations, or whether some of these bleed events may have been sort of preemptive treatment because of fear of a bleed, or some confusion about whether it was a bleed or arthritis, is something that just requires a little bit more investigation. And then when you look at the pediatric trial in the same way, so these are pediatric patients with inhibitors, some of whom had started on bypassing agent prophylaxis. So the bypassing agent prophylaxis in this figure are those long gray bars. When they switched to emicizumab prophylaxis, you can see an even greater number of each of those patients went from some amount of bleeding during the year to essentially no bleeding. So seemed to respond really well to emicizumab prophylaxis. Again, you'll note a few at the top. It wasn't 100% or perfect for everyone, but for many patients, a dramatic increase. Now, Dr. Parnes already went through the HAVEN 3 data, so I'm not going to reiterate all of the wonderful things that he told us, but I will just mention this. So emicizumab prophylaxis compared to factor VIII prophylaxis in non-inhibitor patients. So they also did an intra-patient comparison in about 48 patients on this part of the study as well. And what this means, intra-patient comparison, is they took a group of patients who were on factor VIII prophylaxis and monitored them, and then took the same group of patients and looked at their bleed rate on emicizumab prophylaxis. And what you can see is that for this particular group on factor VIII prophylaxis, they had bleed events. So about the 50th percentile was around 5 bleed events per year. Again, there's a range around that. Some, the 25th percentile as low as 3, the 75th percentile as high as 7. And so when you compare them to how they were doing on their emicizumab prophylaxis, their bleeding got much better. So the 50th percentile here is around 1.5 with that interquartile range, as we call it, of 1 to 2.3. So a few important things here are, one, for patients who are bleeding on their prophylaxis, emicizumab may provide a good opportunity to reduce the number of bleeds that you're having on prophylaxis. So individuals who bleed on prophylaxis for reasons that we don't know, they're adherent to their prophylaxis, but they have injury, they still have spontaneous bleeds, they have issues with their joints, may benefit. Those who are not able to be adherent for their factor VIII prophylaxis because it's difficult venous access, or it's difficult to remember, or their body gets rid of, clears factor VIII so quickly that they need to infuse so frequently it's next to impossible. All of those patients may benefit from something like emicizumab prophylaxis. However, for those who have 0 bleeds per year or 1 or 2 bleeds per year on factor VIII prophylaxis, might be a little bit different than this group that was included in the study. They may still do just as well and have 0, 1, 2 bleeds on emicizumab prophylaxis. So it might be a lateral move in terms of bleed treatment prevention, but it may be beneficial for them if they're having trouble with venous access or other issues. But they may do just as well on their factor VIII prophylaxis if they have a routine and they're not having access to venous issues and they're not bleeding. What has gone not so well for some of the patients receiving emicizumab? So I pulled this table actually right from the package insert, so that small white piece of paper that gets folded in about 32 different squares and inserted into the box. And this table looks at adverse events or symptoms that people developed while participating in the clinical trials. And this list is limited to just those most common symptoms. So if at least 5% of the people participating in the clinical trial had a symptom, it ended up on this list. So the good news is it's actually a pretty short list. And as Dr. Parnes mentioned earlier, really the most common thing that we experienced were injection site reactions. And that's not at all uncommon for medications that you're injecting under the skin, for subcutaneous medications. And across the bottom, there is a little asterisk that gives you some description of everything that falls under that category of an injection site reaction. So if one had a little bit of bruising or slight discomfort or redness or bleed or pain, all of that would be potentially considered an injection site reaction. There was a small number of people that experienced fever. There was some headaches, some diarrhea, some joint pain, As you can imagine, as you go less and less common, it's basically every symptom that you hear when you are listening to the ads on TV at night with various medications. So a lot of these may or may not have been actually related to the emicizumab, but they were reported in patients taking the medication, and so they are listed here. There were also some more serious adverse events that are important to know about. So one is often referred to by an acronym, or TMA. And TMA stands for thrombotic microangiopathy. So I think you can appreciate why we just refer to it as TMA. Thrombotic microangiopathy is a group of disorders, and really it results from injury to the smallest blood vessels and results in sort of micro blood clots. And this can cause destruction of red blood cells. It can cause a drop in the platelet count. It can cause organ damage. And there's a lot of different things that actually fall under this umbrella. And exactly the cause of why people might get TMA with emicizumab is something that's still under investigation and not well understood. This is more data that is put out through the sponsors. So La Roche, Genentech are, as they get new information, are updating on their website adverse and serious adverse events. And so the most recent data cut that they have presented to the public presently is as of October 22nd. And you can see that during the clinical trials, there were 3 cases of TMA. And it happens that all of these cases of TMA occurred in conjunction with inhibitor patients who were using bypassing agents to treat a bleed, and one particular bypassing agent, the APCC, which some people refer to as FIBA. And so what they noticed is that these types of TMA events seem to be related to the co-use, the using at the same time emicizumab prophylaxis with APCC, particularly if higher doses of APCC were used or if multiple doses of APCC were used. So initially, all the events happened in that Haven 1 study. There were no such events that occurred in the Haven 2 or pediatric study. And there has been one additional event that has happened that has occurred since the product was licensed. But in this particular case, although there is specific guidance about trying to avoid using APCCs and some special dosing recommendations if one does use APCCs, the individual that ended up having this event did use more than 100 units per kilogram in a 24-hour period for more than 24 hours. And so fits with the potential risk. I will mention that not everyone who ended up using an APCC along with their emicizumab prophylaxis ended up having a TMA. It was about 10% or so of patients, but really it has something to do with the higher dose or the more frequent usage that seems to put people at risk. There were also a few episodes of thrombosis. So a thrombosis is an unexpected or undesired blood clot. And this is a similar table taken from the company's website as well. Again, the data cutoff was October 22nd. There were 2 cases of thrombosis that occurred. Again, these happened in the Haven 1 trial. So this is the teenager adult inhibitor trial. These cases of thrombosis also happened in the setting of emicizumab prophylaxis plus using APCC, and also happened with higher doses or more frequent doses of APCC. So it does seem that there's something about the contents of emicizumab and the contents of APCC that together that creates more efforts at hemostasis and potentially more risks for clotting. So far, they have not reported any additional episodes of clot in the post-marketing setting, so since it's been approved. So the net sum of this is that caution is required with use of APCCs or FIBA for patients receiving emicizumab. And if you pull out that package insert, you will see that there is a black box warning about the risk of thrombotic microangiopathy or TMA, along with thromboembolism or abnormal clots. And so that there is advice about limiting the dose and limiting the use of these 2 medications together. It's also important to think about the immune system response to emicizumab. And so I think this is something that all patients and families think about with respect to inhibitors against factor VIII. Well, is there something analogous, an inhibitor against emicizumab? So anti-drug antibodies have developed in about 18 patients across both the dose finding, so those very early studies, as well as the HAVEN program. 3 patients have developed neutralizing antibodies, but only one patient, and that was a pediatric patient in the HAVEN 2 trial, actually had significant enough reduced efficacy that they discontinued emicizumab, but were fortunately able to resume treatment with his previous medications. And so sometimes people get a little bit confused about this idea of, well, how can you have anti-drug antibodies but keep using a medication? It turns out that even though the body has an immune response and creates antibodies that we can test for and detect in the blood, sometimes those antibodies exist, but they don't interfere with the function of a drug or a medicine like emicizumab. And sometimes those antibodies develop and they do interfere. They either cause the body to break it down more quickly, or they prevent the medication from binding where it needs to bind. And so in 3 of the 18 patients with antibodies, we had that problem where they could actually see that it was impacting how the body was processing the drug, but only one seemed to have a significant decrease in efficacy. I think it's also important to talk about some of the deaths of patients on emicizumab. And so this is something else that you will see that the company is being transparent about and trying to update individuals about on their website. The most recent fatality data that I've seen presented was as of August 20th, 2018. At that point, there had been 7 deaths, and you'll see that 2 of them happened in some of the clinical trials, including HAVEN 1, but many of the other deaths occurred in other programs to help give individuals access to emicizumab. So the expanded access program, the compassionate use program, and one in the post-marketing setting. One of these deaths occurred in the United States. 6 others occurred ex-US or outside the United States. 6 of the patients were patients with factor VIII inhibitors, and one of the patients had acquired hemophilia A. So acquired hemophilia A is when the body also develops an antibody, essentially an inhibitor to factor VIII, that is different from congenital hemophilia, which is the focus of our group. The causes of death were varied, so rectal hemorrhage, sepsis, intracranial hemorrhage, pseudotumor, GI perforation, sudden cardiac death, head injury. None of the deaths were ascribed to being the result of emicizumab. And I think it's, when you have deaths and fatalities in patients who are not part of clinical trials, who are either part of other access programs or even post-marketing, it's actually really hard for individuals and even drug manufacturers to get information and data on exactly what happened to those patients or what the clinical circumstances are, even when they try really hard. So we don't have all of the information about the clinical situation and what the causes of death were, and we won't ever likely get more information on these patients in particular. I do think it's worth noting that while none of the company and none of the providers ascribed the deaths to emicizumab, that several of the causes of death were related to bleeding. So whether emicizumab didn't provide enough hemostasis, and as Dr. Parnes mentioned, emicizumab is used for prophylaxis. It's not used for acute bleed treatment. And so we understand that in certain situations you may need additional factor VIII or you may need additional bypassing agents to help the body clot satisfactorily. So whether emicizumab was not enough, or whether emicizumab's presence in the blood interfered with doctors' assessments of bleeding and laboratory assays, is just something that we don't have a lot of information on right now. So I think that's a nice segue into what do we need to learn more about. So I will tell you that MASAC, or the Medical and Scientific Advisory Council for the National Hemophilia Foundation, has put forward some recommendations. And these, as you can see highlighted in yellow, first focus on hemophilia A with inhibitors. Additional recommendations for hemophilia A without inhibitors, I'm sure, will be out soon. These recommendations focus on acute bleed management as well as use of laboratory assays. I would recommend just Googling MASAC and emicizumab if you're interested in reading this, but you will have access to the presentation later, so there's the full link if you're interested in the PDF of the full recommendations. But just to give you a high-level overview, some of the initial recommendations focus on the general approach to breakthrough bleeding. So it remains true that significant, serious, or life-threatening bleeding should continue to be treated promptly. But as we heard, it's going to be important for patients on emicizumab, whether inhibitor patients or non-inhibitor patients, to contact their HTC, their Hemophilia Treatment Center, if they're uncertain if they're bleeding or if they have a minor injury and they anticipate that they might bleed. Because what we've learned from taking care of many patients on emicizumab is sometimes bleeds aren't bleeds and you actually don't need more treatment, or sometimes minor injuries don't no longer lead to bleeds and so you don't need additional treatment. So we don't want you to delay treating an actual bleed. When there's uncertainty, it's really important as you're getting used to this new medication, and a lot of the hemophilia treatment centers are getting used to this new medication, that there's good communication and talking through the plan. Muscles and joint complaints should be evaluated prior to additional treatment. So when knees are swollen or hips are swollen or elbows are having problems, especially if you've treated them with additional medicine and they're not getting better, it's more of a reason to come in, have it looked at, potentially consider an ultrasound. We also have to be cautious, as we've heard, with the dose and the duration of bypassing agent prophylaxis, bypassing agent therapy. So the recommendations from MESAC are to avoid the use of APCCs or FIBA for breakthrough bleed treatment, understanding that sometimes bleeds might not be controlled with recombinant 7A or other modalities. And so there may be some situations where the use can't be avoided. In those situations, we should limit the initial dose to sort of a similar, potentially a bit of a lower dose than we might have otherwise administered for people not on emicizumab therapy, and be cautious not to exceed more than 100 units per kilo per day, and hopefully not need to exceed multiple days. Recombinant 7A should be the first option for treatment. And similarly, rather than potentially starting at higher doses, as some of the inhibitor patients may have used in the past, starting with a baseline of 90 micrograms per kilo, potentially even lower as the initial dose. And again, being thoughtful to repeat dosing. All the repeat dosing really should be done under medical supervision. So that doesn't mean that you have to be in the hospital or coming to us every day. But again, having that good communication so that we can understand what's happening, verify ongoing bleeds, and monitor for signs or symptoms of abnormal blood clots. So things like the thrombosis or the TMA that we spoke about in some of the previous slides. It's also important to remember that emicizumab interferes with our standard coagulation assays. So all of the usual assays, and you can see a list of the long names that we give to them that fit in our coagulation labs, where we usually check factor VIII levels or PTT tests or inhibitor tests. Emicizumab actually interferes with those tests, so we're no longer able to use our regular laboratories to monitor things. Fortunately, laboratory monitoring of emicizumab is not required while you're on routine prophylactic dosing. There are no factor VIII levels, so partly that's because the factor VIII levels that we can usually send are interfered with by emicizumab and will be misleading. So with emicizumab in your bloodstream, if we were to send off a PTT test or a factor VIII level, it would report back at normal or maybe even really high levels, so 400, 600, 800%. And that's not because emicizumab is giving you a factor VIII level similar to 400, 600, or 8%. That's really because it's interfering with how the test works. Emicizumab has a long half-life. So Dr. Parnes mentioned this. It's about half-life, so the time to get to 50% of the dose is about a month. So this means that if you stop emicizumab, the interference with the labs can persist for 5 to 6 months. Because once you stop a medication that has such a long half-life, it's going to take a long time to completely leave your system. And even at low doses, we will get this interference. So it's not like a quick on, quick off. I stop it today, next week I can use my labs and check a factor VIII level. It actually takes much more time than that. If there's a concern that there's a loss of efficacy of emicizumab, so if you're doing really well on prophylaxis, and then all of a sudden you start bleeding more frequently or have a lot more bruising, in those cases, one of the clotting tests, the PTT, may be helpful because it should be completely normal. And if we see the PTT test, which should be interfered with and should be completely normal, if we see that starting to get longer, that may be a signal to us that the emicizumab isn't working quite as well as it used to, and maybe the body has developed an antibody and is clearing it more quickly. So in some special situations, that might be helpful for hemophilia providers to learn more about the emicizumab in your body. There's also a limitation in the factor VIII inhibitor levels. So it turns out that even factor VIII inhibitor levels usually use these PTT-based tests. In the inhibitor patients may recognize, we sometimes refer to these as a Bethesda assay. And so these are also not reliable. So on this medication, if I sent your inhibitor titer to my regular lab, it would come back undetectable or as a 0 inhibitor. Fortunately, we do have some laboratories, and the Centers for Disease Control, or the CDC, is just one example that can provide an alternate test so that we can have a sense of this. So just to wrap up on a few things that hopefully you'll take away on emicizumab. So what's been learned? So the indication is only for hemophilia A. It can be administered as a subcutaneous injection. The dosing frequency is weekly or potentially every other week or monthly. It seems as an effect to have good bleed reduction for patients both with and without inhibitors, certainly compared to on-demand treatment and also compared to prophylaxis if people are having bleeding on prophylaxis. And remembering that there's no specific monitoring for emicizumab, but it interferes with our usual tests. So whether you're here at the HTC or whether you are in emergency rooms or traveling, knowing that is actually a really important piece of information to share with the doctors taking care of you. What needs more investigation? Well, it turns out we have a lot of really great clinical questions and a lot of details that need more investigations. So how do we optimally use emicizumab with bypassing agents or with factor VIII for bleed events? So there, as you heard from the clinical trial, there were some minor bleed events. There have been some very minor procedures that have happened, but fortunately no one on the clinical trials really experienced major traumas or major surgeries or severe illness. So how changes in the body's inflammatory status and different changes in the body's physiology impact emicizumab, and using these other coagulation medicines is something we just need more time to explore. We also need to learn a little bit more about how to use emicizumab in specific populations. So POPs for previously untreated patients. Emicizumab has essentially been approved from newborns throughout all of life. So even though there's pretty limited data in those youngest patients, this is a subcutaneous medication that may provide good prophylaxis and potentially prevent, even with low frequency, intracranial hemorrhage or bleeding in the head in the youngest patients who aren't yet on prophylaxis. For individuals who get an inhibitor, should we still try in some way to eradicate the inhibitor, use emicizumab to prevent bleeding, and then use factor VIII to still try to get rid of the inhibitor, and in the future provide patients with all different treatment options? And how to do that is something that's being investigated as well. Also, we need to learn something about the variability of interperson bleed control on emicizumab. So everyone essentially has pretty similar dosing and has little bits of variation in the concentrations of the drug in their blood. But how much prophylaxis is that? We don't have a factor VIII equivalent number to provide for people on emicizumab. And so is it safe for prophylaxis when you're reading a book and playing the trombone? Is it safe for prophylaxis when you're heading out to a varsity soccer game or heading out to the mountain to do some downhill skiing? What level of protection do you have? So that's something we're going to have to learn a little bit with some more clinical studies, and also on a patient-by-patient basis, partly because it's hard to understand and study some of those things, and partly because there will be, just like for people on factor VIII prophylaxis, variability in how much individuals need to prevent bleeding. We're going to have to learn more about the frequency of antibody formation against emicizumab. And we're also going to have to learn more about the long-term musculoskeletal outcomes of emicizumab prophylaxis compared to factor VIII prophylaxis. So as Dr. Parnes emphasized, emicizumab is not factor VIII. Emicizumab does the function of a clotting factor and in many ways works similar to the factor VIII, activated factor VIII clotting protein, but it's not an exact mimic, and there are some functions and some details that it doesn't match perfectly. So is there going to be a difference in how people do long-term on the emicizumab versus factor VIII? And that's something we're just going to have to learn over time. So with that, I will say thank you, and I'm happy to turn it over to Rich for any questions.
Great. Thank you so much, Dr. Parnes and Dr. Croteau. That was a great overview of this new treatment. It is 7 o'clock, but if it's okay with both of our physicians, we can ask a couple of questions here since the queue is filling up. The first question that I'm going to ask is great. With IV injections, this is the question, with IV injections, it's easy to tell when you have a good stick and you get a blood return. Is there a risk or not a risk of getting a sub-Q injection right? How forgiving is it that you go too shallow or too deep? And how would the patient know that they injected the medication correctly?
That's good. Getting ready, I guess, for a transition. What I would say is, the needle's very small, so it's going to be hard to go into the wrong place. Most important, I would say, is making sure that the site is clean. So using an alcohol wipe to clear off the area so that there's no contamination. And you'll know if the injection is too shallow because you'll see the medication not go in. It will leak down your abdomen, or it will come out of the skin. So in that situation, you should immediately stop the injection and try again. Otherwise, you're not going to get the treatment. And for the most part, the sites that we inject subcutaneously, like the abdomen and legs, for instance, these are wide areas that are safe for injection, and it's really impossible to miss that target.
Fantastic. Thank you so much for that answer. Dr. Croteau, if you don't have anything to add, I will go on to the next question.
Perfect. That's fine.
Great. Is there any data or scientific thinking about this new therapy for HIV-infected patients taking HAART, H-A-A-R-T?
As far as I know, there's no drug interactions. I don't know, Dr. Croteau, do you know any different?
I haven't seen any drug reactions reported, and because emicizumab is an antibody, it's broken down by the body in a different way. So a lot of times when there is drug-drug interactions, we think about liver metabolism and different enzymes or proteins in the liver that are responsible for breaking down one versus another medication that can cause changes in levels of efficacy. But emicizumab is a little bit different. So I haven't heard any concerns that there would be problems for individuals on hepatitis C therapy or HIV therapy or any of these other medications.
I will add that what's reported on the label is nothing about those kind of treatments. The main thing being bypass agents, specifically FIBA.
Great. Thank you very much. Another question that came in is, I've heard this new therapy being called by two different names. Is there a name that we should refer to it as, or is there one that works better than the other?
Yeah, that's a great question. So as physicians and a lot of your medical providers, we tend to default towards generic names of medications. So that would be emicizumab. This medication is also referred to as Hemlibra. So that's the brand name, if you will. So for many people, Hemlibra rolls off the tongue a little bit more easily than emicizumab. But it's not right or wrong to necessarily use one or the other. But most often you'll hear your providers use the non-brand name.
Great, thank you very much. The next question, and I know this was covered in your presentation, but I think it's good to repeat this. The question is there any testing available currently that can locate a blood clot? Also, how many patients had blood clots while they were on Hemlibra?
Yeah, so there were 2 patients that were reported to have blood clots. And the answer is, for the testing of blood clots, the answer is yes and no. So we don't have any great tests that necessarily predict whether a person with no symptoms has a blood clot. There can be some blood tests that might give us a hint or a clue that we should follow a patient a little bit more carefully. But there's no sort of definitive blood test that we could say, yes, this person has a clot or doesn't have a clot. Once people develop symptoms, we certainly can look with different imaging modalities. So, for example, for individuals who get pain and swelling in their leg, we may use an ultrasound. Or if they have difficulty breathing or we're worried about a clot in their lungs, a pulmonary embolism, we might get a CAT scan. So we do have testing that we can do when we're specifically worried about a clot. But that's part of the reason the communication becomes so important for individuals using multiple doses of, say, recombinant 7A or APCC or factor VIII, because there's not one blood test or one way that we know, yep, you're at huge risk of a clot or you have a blood clot. A lot of it has to be discussion and symptom management and just ongoing careful assessment.
Thank you very much, Dr. Croteau. Another question that actually came up twice here is what is the proper way of setting up a medical ID when you're on this new treatment? Is there a best protocol? As I'm summarizing these 2 questions that came in, but it's about medical IDs and how to properly set up when you're on this new therapy.
I think by medical ID, they mean medical alert bracelets and wallet cards, identification that is alerting healthcare providers that a person has a bleeding disorder. And I think these are really important tools in terms of patient safety. So, one thing now to recognize is that if patients are doing much better, it's important to remember that they still have a bleeding disorder. So Emicizumab and other treatments so far do not completely normalize the clotting system, but they turn severe patients into more mild patients. So what wallet cards need to say is that the patient still has a bleeding disorder, hemophilia, and it should still include contact information for their treatment center and their providers. If they're taking Emicizumab, I think it will be really important for the card to say that there is a possible interaction with a specific bypass agent named FIBA, and that treatment should be avoided for acute bleeds. And in fact, what our strategy has been is to list FIBA as an allergy in the medical record so that other providers don't administer that without checking with the hematologist first.
Yeah, and I think part of the challenge is, whether it's a medical alert bracelet or the medical alert medallions, there's just such a limited character number to put much information. So I completely agree with Dr. Parnes that really the key information is still that there's a severe bleeding disorder. And one can choose to list Emicizumab on the bracelet, but you have to certainly recognize that if you're coming into your hemophilia treatment center, because there's an emergency room at that facility, they will have that information in your record. And many emergency room providers, especially those that practice in community hospitals and outside of the hemophilia treatment center setting, will have never heard of Emicizumab, and there's a lot of MAB drugs out there. So they will probably have, they've happened to hear one of our lectures or are particularly interested in bleeding disorders, they will have no idea what that is or what that means. So I would really prioritize still the characters for focusing on the bleeding disorder. And then in places where you have more space, so whether it's the wallet card, whether it's the online information, putting more information there about avoiding use of APCCs, about avoiding certain coagulation tests, or certainly obtaining them with caution and caveat that they likely are not going to be informative and reliable is important. And for the folks at my center, you will recognize that we provide travel and school letters. So for individuals on Emicizumab, we incorporate this language into those letters as well. And so when you're setting up your medical alert, whether you're here at our center or any of the HTCs within New England, we can help provide you with some bullet points and language to help get that right. But for those who've had bracelets for a long time and don't necessarily always renew the online piece, when you switch to Emicizumab, that's a really good time to reevaluate what's on your bracelet and to be sure to renew and update the screen that the emergency providers can access.
Great answers from you both. This is the last question this evening, and I'll turn it over to either one of you. But and it's more with insurance side, so not sure if you can answer this. But the question is, I fear my insurance will not cover this as I have moderate hemophilia. Have you heard of other cases with moderate or mild patients switching to this product and having a problem with insurance paying for it?
I think right now we're having problems with insurance with severe hemophilia. So it's not just moderate, but you know, it's a new treatment. It is expensive, and it's going to take some time before all of these carriers are on board. We've been working really tirelessly in the last few weeks as it gained further approval, because patients have been asking to switch, and we're waiting to hear back from insurance carriers. I know today we got a denial saying that, well, the patient doesn't have an inhibitor, so they're still basing it on the old criteria. But you know, we're going to keep trying and working with the insurance companies to educate them and get everybody the treatment that is needed and that you deserve.
I would really encourage people to continue or to start maintaining infusion and bleed logs. So some of the ways that we're able to effectively communicate with payers and insurance companies is by demonstrating the importance of a medication. So if you're doing fantastically well on your factor VIII prophylaxis, you're infusing twice a week, 3 times a week, you're never having any bleeds and things are going really well, it's actually, depending on the insurance, maybe more difficult to get Emicizumab covered for you up front. But if you're really struggling with adherence because of poor vein issues, documenting that is important. If you're having frequent bleed events, making sure that you log that and communicate with your hemophilia treatment center, that's important, because if we can show this individual is having to infuse, 4, 5, 6 times a week, because even on top of the prophylaxis, they're having bleeds, look how frequently they're bleeding. We need a better alternative because this is not treating their hemophilia well. It gives us the opportunity to demonstrate to them how it's really of clinical benefit, both for you, but potentially they also can see the benefits on their side as well. So the better you can do documenting all of these things, especially early on, the more that will help us advocate for you to get access to some of these new therapies.
Fantastic answer from you both. With that said, just want to thank both of our physicians for spending time on a Tuesday evening with us for a fantastic presentation about this new therapy. A recording in its entirety will be posted by tomorrow on NEHA's YouTube channel, so you could watch it and share it. But with that said, thank you very much, Dr. Croteau and Dr. Parnes, for spending time and for doing this presentation. Thank you all for listening in and asking such great questions. And we wish you a great night, and thank you again.
Thank you.